America is home to 33 million small businesses, the beating heart of communities across the country.
And proof that the American dream is still alive.
This is a show about those dreamers and doers and the communities they serve.
Their real life stories.
Their struggles and successes.
Their grit, determination, and passion.
And the people who fight
to keep their American dream alive.
I'm Alfredo Ortiz.
I'm Elaine Parker.
And it's time for another episode of Main Street Matters,
America's small business megaphone.
Hi, and welcome to another episode of Main Street Matters, America's small business megaphone. I'm Elaine Parker, the president of the Job Creators Network Foundation.
And I'm Jordan Bruno, vice president of Job Creators Network.
Please subscribe to the show at salempodcastnetwork.com or wherever you get your podcasts from. Today, we are pleased to be joined by Dr. Robert Campbell. Dr. Campbell is an anesthesiologist in Lebanon, Pennsylvania. He received his medical degree from the University of Maryland School of Medicine and has been in practice for more than 20 years. He's also part of the Job Creators Network and just had an op-ed published titled "Bipartisan Legislation is a Good First Step in Rolling Back Government Drug Price Controls." Dr. Campbell, thank you for joining us on Main Street Matters, America's small business megaphone.
Well, I'm pleased to be here, and I'm always happy to talk about the things that matter the most to the people on Main Street.
Absolutely. Well, we've been working with you for quite a few years. We met you back when we first were working on healthcare policy with Physicians for Reform, and we were developing the healthcare framework. We call it Healthcare for You, which really focuses on free market healthcare alternatives that re-inject the free market back into the healthcare system to create more choice and competition and really help protect and restore that doctor-patient relationship. So I know we've kind of had this back and forth with you, and you've helped us on a lot of the policy ideas that were behind that plan. Can you first off just tell us about your background and what you do, how you I know you're obviously a doctor, but you've also moved into this policy area that you really, you're just kind of an expert at. So I wanted to delve into that a little bit with you.
Yes, sure. I guess some people, I've had a winding, twisting journey. I went to college at the University of Maryland. I was the first in my family to go to college. And I loved science, and I studied science, and I was all lined up to be a physicist at a major institution. And I just kind of started thinking about science and how can I help people. And being in a nuclear reactor or a physics lab or something like that just didn't seem to be as real as medicine. And that's how I kind of got into the medical field. I said, this is a way to take science and help people. So I went to medical school and ended up doing my residency in anesthesiology and pain management. I've had a wonderful long career doing that. And I've truly, the thing that gets, when I get up every morning, I just love being able to help people. And it's a special kind of work that I do. But I noticed with time that the healthcare, our system, just seemed to be creaking a lot, and then it got to where it's just, I think it's run off into a ditch. And I remember early in my career where I had my wise attendings telling me that we are spending 8% of our gross domestic product on healthcare. That's unsustainable. If it ever gets to 10%. The whole thing will collapse. And of course, now we're at 18% of GDP. Right. And as I often say, I'm getting a little older occasionally, I have to access the healthcare system. At 18% GDP, you can't see a doctor. So that's how I kind of got involved in some policy, trying to understand the system better and trying to make it accessible, because I think healthcare is so special. If you can deliver healthcare to people, it's just the most human thing you can do, and I just think that our system is preventing that. And I love the work that JCN is doing at trying to find a path to make healthcare affordable and to make it personal again.
Wow. Well, thanks a lot for joining us, Dr. Campbell. Let's turn the conversation, if we may, to drug pricing. And look, I've looked into this. I've tried to study it over years and years, and I feel like I maybe have got 5% deep into it. It's just one of the most complicated issues that I've ever studied, at least from a policy standpoint. Can you give our listeners and viewers a little bit of an overview of the prescription drug supply chain, and maybe explain how it differs so dramatically from, say, the supply chain of soda that a restaurant company might be purchasing, or hot dogs that different grocery stores might try to bring in, or a regular commodity like that?
Yeah, I'd love to. And since I live here just a stone's throw from the Hershey chocolate factory, we'll talk about, chocolate as something that would be something that American ingenuity created, the ability to mass produce chocolate. Milton Hershey at the turn of the last century. No one thought it could be done. At that time, only royalty and very wealthy elites could have access to chocolate. And he developed a way to mass produce it. Now, today, if you think about anything like that, a chocolate bar is affordable. When things change in the marketplace, like a normal supply chain, right now, cacao plants, cocoa, is at an all-time high for cocoa powder, and you'll see it in the price of chocolate bars. But isn't it the way that markets work, that when we have a shortage of cocoa powder, there are new cacao farmers who come in, they plant trees, they increase the supply, and eventually, due to price, we will have more cocoa powder, and then the price of chocolate will moderate again, and Hershey will be more profitable. And that's a normal supply chain dynamic that works. Healthcare in general is not like that, and prescription drugs are not like that either. Normally, we have what we call big pharma. There's about 24 very large international research pharmaceutical companies that discover new molecules, get them approved, manufacture that, and deliver it through the supply chain. They're not the main issue with determining the price. In 1987, Congress introduced a form of a anti-kickback safe harbor that allowed things called pharmacy benefit managers to write the contracts for the supply chain all the way through, from the manufacturer right to the pharmacy where you go to pick it up. And they're not a real middleman in that they don't ever really purchase or have the drug, but they just simply write all these contracts. And there's a whole system of rebates. So what you pay at the pharmacy may have nothing at all to do with what the manufacturer cost of goods sold is, or what they would even charge to the real middleman into the pharmacy for the drugs to get to you. So there's this very bizarre, very opaque version and of a supply chain, which if I wrote it on a whiteboard, and in fact, I did a 60 Minutes segment, CBS 60 Minutes, about a year ago, summer. And the whiteboard got so filled up with arrows and dollars and medications and contracts that no one could make sense of it. And that was the point of the segment, is at the end, everybody said, does anybody in the room understand this? And the answer was no. So, Jordan, you're not alone in not totally understanding this. But I will say that the pharmaceutical companies, I'm a big believer that price caps have never worked for anything, anytime, anywhere. We've had price caps in Germany between World War I and World War II, which didn't work. The Russian communist governments had price caps. Cuba. America had price caps. In the early 1970s, we had price caps on wages, on gasoline, natural gas, meats, eggs. They just never worked. You had the price cap and the price was predictable, but then at that price you could go. You just could never buy the product because it wasn't on the shelf. And that's my fear for the government wanting to introduce price caps. We need innovation and we need the manufacturers to make those drugs because there's a lot of health conditions that we still have not conquered.
So can you explain to our viewers and listeners then what the Inflation Reduction Act is doing to the prescription drug supply chain and the consequences of it?
Well, when we count on American innovation and drug company innovation. If you take that away, we will not have cures for diseases going forward. And the thing that I would tell you is that if you relied on the government to just do all the medical research to cure things, you would get what the NIH budget has, which the NIH budget, if you look at the top 20 conditions that they do research on, it's really what the top 20 things that the politicians want to be studied for optics. And a perfect example, the number one NIH research item, 25% of NIH money goes to AIDS research, which is a very 80s disease, and I have a lot of compassion. We still have AIDS, but it's really something that we can manage, but that's 25%. On the flip side, 2% of our budget goes to asthma, which is an epidemic with our children. Colon cancer, instead of 25%, 2% goes to colon cancer. So the research pharmaceutical companies, driven by demand for products, they are more in tune with what American health needs are. So that while the NIH may not see colon cancer as a big deal, the pharmaceutical companies prioritize that because they know that the rates of colon cancer are skyrocketing right now. And so we need those kind of free market forces in place. And the Inflation Reduction Act, if you want to look at pharmaceutical price inflation, if you wanted, the Senate Finance Committee wanted to subpoena somebody in there to get the real story on why we have drug inflation, it would be our policy. So you would subpoena a mirror, and the senators could look in the mirror and say, this is why we have inflation, because we have the wrong policies. We need free market incentives, and I'm fully convinced of that. And the free market will make it so that crazy, out of alignment price drugs just can't survive in the marketplace.
If you had a magic wand and you could decide how to fix it, what would that solution look like?
Well, I think the key, if you had the first step, would be price transparency. Mm-hmm. So there are 3 pharmacy benefit managers, and I'll name them because I've named them many times, and they say, well, you shouldn't get specific, you'll get in trouble. But CVS Caremark is one, Express Scripts, and OptumRx. Those 3 pharmacy benefit managers control the supply chain for 90% of prescription drugs. And as crazy as it is, our policymakers have allowed those companies to have secret contracts. You'll never see those contracts as to what the costs are along the supply chain. And they also allow this system of rebates, which are kind of legalized kickbacks. And I was very fortunate. I dug into this in a deep way with the price of insulin. And we had a third-party blinded process where we looked at insulin, which was $300 for a prescription. It turns out the cost of manufacturing is $25, and we could we could get it through the supply chain somewhere at $50 to $100, and it could be profitable. Fast forward to today, Congress has acted on that, and the drug companies and the pharmacy benefit managers have all come together and said, let's not have rebates in our insulin supply chain. And the price of insulin now has gone from $300 to, $50. We could do that across the board. The best study that I'm aware of is that 47% of the cost of a prescription drug at the pharmacy counter goes to these so-called rebates. And nobody knows where that money goes, although we know that there are Panama and Swiss banks involved, which means there's something that they don't want us to know about. So if I had to do one thing, I would say those 3 PBMs are required to have price transparency. That's something that I've done in Pennsylvania that we're working on. It's something that's been done in Ohio. It's been working on that in California and Texas. I will say whenever that the contracts are revealed, you suddenly see where all the money's going. And so that's what I would do. Those 3 PBMs, they either need to not be allowed to have a hidden rebate system, or have transparency of those contracts. The other thing is, inevitably with corporations and government, there are allowed to be these conflicts of interest that are developed. And I'll tell you one example that's just very granular, but it exists across the 3 PBMs. I have Aetna insurance. Aetna uses CVS Caremark as the PBM, and I have to go to CVS Pharmacy for my prescriptions. Now, the government, in its wisdom, has allowed CVS Health to own the PBM, CVS Caremark, and the largest pharmacy chain. They've now bought CVS Pharmacy, and they also own the 3rd largest insurance company, Aetna Insurance. So when I take my prescription to CVS Pharmacy, it's all an internal exchange of dollars. There's no incentives for anyone to have any savings in that supply chain, because every dollar stays within that same group of shell corporations. I think that's a conflict of interest which could be busted up, should be, and would lower the price of drugs. So those are my big 3 things. No more rebates, PBM transparency, and the conflicts of interest. The PBM should not be, the 3 PBMs own the 3 largest health insurance companies. That is a direct conflict of interest that is intentional to inflate drug prices.
Wow, that's a lot there to digest, but I look forward to really chewing on those solutions. I think it's sometimes kind of ironic, us in the free market, huge capitalists, believe in free market innovation, but then we're also working within the levers of power in government to change policy. So I personally, I'm sure I'm speaking for Elaine as well, and probably you, Dr. Campbell, get really excited when I see free market solutions to government problems. So from sort of a lay perspective, I've been following Mark Cuban's Cost Plus Drugstore, which from what I can tell obviates the whole PBM scheme and seems to offer great discounts. But obviously I am a biased observer of this because I see that and I get really, really excited and probably don't look critically at it. So could you maybe just give your thoughts on that as a potential solution and the positives and drawbacks?
Yes, absolutely. The first such effort was by a guy named John Scully, who was the past CEO of Apple. He started a PBM which had no rebates, never really got successful. Mark Cuban came along and said, wow, look, let's learn from that, and I want to do the same kind of thing. And so really what he's created is he's given you another road to take where you will not have rebates. That's the basis of the success that Mark Cuban is having. It's called Cost Plus. They've only been in operation for 2 years. You will go, if you go to the Cost Plus route, I recommend every drug you ever get prescribed that you check an alternative like Cost Plus as an option. What you will do is you won't use your insurance money because, Aetna or any of the other big insurance companies won't let you do that. You'll pay cash. But for me, I had a drug that I used through Aetna that I went to the CVS pharmacy and the whole price was about $600, $150 from me, $450 from Aetna, and I was thrilled, like, wow, like I only have to pay $150. Thank goodness I have insurance. We can go to Cost Plus and get it for $10. So that's, in some examples, it is extreme. And Mark Cuban is doing this for all the right reasons. I will tell you that from a policy perspective, one of the few things that our government has done, Senator Cassidy from Louisiana, we did get a bill passed that's called the no gag rule for prescription drugs. So when you go to your pharmacist, you can ask your pharmacist, okay, this is my prescription, this is what insurance pays, this is my copay. What if I don't use my insurance? What's the best deal I can get? You can do that, and contractually, the secret PBM contracts would not allow pharmacists to have that discussion. Now that you are allowed to have that discussion. So I think that would be step one. Step two would be just to go to Cost Plus and log in and check every prescription you ever use. There are some examples. I know AMAC, the Association of Mature American Citizens, is a retirement organization where you can go on their webpage and get price transparency on prescriptions. Not everything will be covered with Cost Plus because of different arrangements, but it is the first and best step anybody can do. Take advantage of the no gag rule. Ask your pharmacist, are you willing to help me in this way with every prescription I have? My sister, her best friend, is a nurse, and her husband had bad diabetes, couldn't afford $300 a month insulin without insurance. Found out that they could go through Cost Plus and get it for $25. She retired early as a result of that because she could, because of that need to have that insurance coverage was less important. But what they do, it's like a fireman, like a rogue fireman who sets a fire and then comes to set up to put the fire out and to be the hero. Your insurance company's not the hero on this. They are part of the intentional price inflation. If you look at what inflates the most in the American economy, number one is healthcare, number two is higher education. It's the two things where the government is most involved in. So we have to find ways to skirt around the edges, price transparency, becoming smarter about how the system works. And boy, that's not easy. I've written an article where I said I put about 10,000 hours before I finally could figure out how the system works. Now that I know how the system works, getting it fixed is something that, Jordan, somebody young and energetic like you is going to have to do.
100,000 hours.
It might take that.
Bob, when Obamacare was first being talked about and Barack Obama would go around campaigning about this grand plan, one of the things that he promised everybody was, if you like your health insurance policy, you can keep it. If you like your doctor, you can keep it. None of that turned out to be true. He also talked about how it would get costs under control. None of that turned out to be true. The only people who don't feel the inflation are the people who are getting the Obamacare subsidies, who qualify for those subsidies. They don't feel the inflation. They're paying $0 to $20 a month. And I'd say they love it, except I'm not so sure that they actually have access, because a lot of doctors don't even take Obamacare exchange insurance. And so they have to travel for health insurance. What are some of the practical consequences that you've seen in your practice of Obamacare on patients directly?
Yeah, the politicians will always work to create a narrative which is appealing to the public, and that's what that was. If you look under the hood, what Obamacare is it's really just a very aggressive expansion of medical assistance. In Pennsylvania, pre-Obamacare, Pennsylvania has about 13.5 million citizens. We had about 1.4 million Pennsylvanians on medical assistance. After Obamacare, we now have about 3 million. So it's more than doubled. And that's where all the uninsured people, if you are uninsured and your income is at 1.5 to 2 times the poverty level or below, then Obamacare will be a chance for you to get some insurance. The problem is medical assistance. Somebody has to pay for that because the government only has so much in tax revenue, and they can only pay so much. And you're right. As a physician, a lot of the specialists just simply don't take medical assistance because the cost of taking care of that patient is greater than what you're being paid for that service. And that's a real problem. The thing that you're seeing is, small businesses that are trying to provide insurance to their employers, to their employees. Employers are finding that those costs are going up 10, 15, 18, even 20% in a given year. And why is that? Well, a big part of it is Obamacare. It really was an expansion of a subsidy as opposed to an alternative for, working Americans, taxpaying Americans, just don't, you can't, there's no advantage to those people to go to Obamacare, and the employers have to pay higher and higher rates to cross-subsidize. Because the insurance companies have to participate in Obamacare, they have to get their revenues from somewhere, and so they're getting it through the private market. So it's part of that inflationary cycle that we're stuck in.
What is your best advice on how Americans can try to take control back of their health care? Because the majority of Americans get their health insurance from their employers. They don't have a choice. They can't go somewhere else. So they can't say, they can't just shake their hands off and say, I'm done, I'm not doing this. That's their only hope. But many of them are paying massive deductibles every year, and it never feels like they have coverage anyway. And it's such a complicated world to even understand how health insurance works. They just need a simple plan that they can afford, and they're willing to pay the premiums, but they don't want to, on top of that, get bills after the fact, and they don't want to pay massive deductibles. Like, how do they get involved? There's so few of you, and there's so few of me and Jordan, and who have at least some understanding of the system and what needs to be done. But getting from point A to point B, we need the masses behind us. So how do we get them behind us?
Right. It's a difficult thing. I think first is surveying the landscape. You have to realize that people the elites, the people who work for the very largest companies that have just gilded health insurance plans and have a lot of resources, they're competing to hire the best people, and they provide really generous health care packages. You can get a fairly low deductible. The premium is sky high, but they're willing to pay that. So the wealthiest 10, 15% are doing fine. The bottom, you're talking about the lowest 20% are on a subsidized Obamacare. But then you have middle America. You have the middle class. And as is often the case in politics, a policy is put forth to help the middle class, and it just turns out to be a burden on the middle class. So I think you have to look at where you exist in that ecosystem. I'm very fortunate. I guess I consider myself to have a gilded policy. Even so, wow, the premium is sky high, but then I don't have big copays. middle class, where most of us live and where I've spent most of my life, is really in the lower to middle class. If you're in that setting, I think one way to start to get the ball rolling is to go to your employer and tell them about the trouble you're having accessing good care. I do think employers, especially small companies, my experience, they love to be able to provide good health insurance for their workers and their workers' families. It's been something that's an American tradition. And I think we have to get back to that. And the only way that middle class America can win in this, I think, is to convince those small company employers to gather their thoughts and to innovate within the system that we have. And I think that introducing some free market elements can happen and can be a good thing. But I think, it would take these business owners to understand where the money's being sucked out, like with the PBMs, the pharmacy benefit managers, understanding that reintroducing some elements of free market, like the no gag rule. I want all my employees to go and ask the pharmacist, how can I not use my insurance product to pay for my prescriptions? And then I think partnering with the health delivery systems, because the health systems, are, especially small community hospitals, even some of the larger systems, are really struggling, where we created these insurance companies which are just giants and they control all the levers. And if we can get small business owners and health systems to partner to lower drug costs, that would be the way to do it. And if you're in middle America, you need to do a little homework, watch this podcast, do some reading, go to your employer, try to get them engaged, because I think it's going to take a political will from the grassroots to cause the politicians to bust up the corporate cronyism which we have right now.
I think that's good advice, actually. And we do work a lot with, Physicians for Reform and looking at other options for healthcare delivery, and try to educate our small business owners on some of those options that are available. But we need to grow that megaphone more so that small business owners start to make that move. There are more small business owners, 33 million of them, than there are corporations, as you described, that are, big conglomerate corporations that are self-insured with the, Cadillac plans, and those people are fine. But there are more small business owners. And if we got them to move as a community in that direction toward the free market delivery health options, I think that we would definitely see what you're talking about, the political will from our politicians. So we just have to find a way to keep beating this drum and getting that message out there.
Yes, Elaine, if I was in control of everything, I would say the insurance companies what an individual needs is a catastrophic plan. It's like a plan that you have on your house. If your house were to catch on fire, you have a policy that gives you that disaster coverage. But your house insurance policy, you don't have to tap into that to pay somebody to mow your grass or to do routine maintenance on your house. Mm-hmm. The insurance industry wants to be everything to everybody so that they control everything. So if we could have a catastrophic plan coverage coupled with innovations where we had cash pay, where we went back to that kind of a model, trust me, the doctors' offices and the health systems would welcome cash pay, where they don't have a third-party insurance company they have to submit claims to and hope that they get paid. So I think if we could get smart people and a unity, that would be the way to do it. Catastrophic coverage, reintroducing cash pay incentives into the existing health system. Because like with Mark Cuban's Cost Plus, if you go with cash, I can either go and pay $550 for my generic cholesterol medicine, or I can go to cash pay and get it for $10. There's more of those savings than we can even fathom that are in the system. And that's what I think would break the back of the monopolists and allow Americans to have access to healthcare again.
I agree. I think we could talk for hours about ideas on how to fix the healthcare system. But I want to thank you, Dr. Campbell, for taking the time to join us on Main Street Matters, America's Small Business Megaphone. And thank you all for taking the time to tune in. Main Street Matters is part of the Salem Podcast Network. New episodes debut every Wednesday and Friday. You can subscribe to the show at salempodcastnetwork.com or wherever you get your podcast from. And we'll be back real soon with another episode.